Welcome to ACCESS's 2025 Summer Research Day. We've run a summer research program throughout the last 6 weeks or so, in which students from across the country have been working on different research projects in different labs. And today is an opportunity for the students who would like to present to the ACCESS community and the pediatric cancer community as a whole to have the opportunity to do so. If you could go to the next slide.
Alrighty, good morning or good afternoon, everyone. My name is Emma McLaughlin. I'm an MD PhD student at the University of Calgary, working with Dr. Nicole Koulos-Reed, and I'm excited to share with you today what I've been up to this summer, which is directly related to my PhD program of research, which is the implementation of physical activity for children and adolescents affected by cancer, or the IMPACT trial for short. Next slide, please. To begin, this showing us fun colors. To begin, physical activity is safe and beneficial for children and adolescents affected by cancer, both on and off treatment. And there's ample research to suggest that physical activity can help to improve a range of outcomes from cognitive functioning, strength, flexibility, energy, mood, and can help to mitigate both the symptoms and side effects of treatment. Next slide, please. Despite the benefits that physical activity can offer, both on and off treatment, many children and adolescents affected by cancer are not active enough to accrue the benefits that physical activity can offer. So recognizing this, as well as taking a look at the literature to better understand some of the barriers that children and adolescents on treatment face to being engaged in physical activity, we developed IMPACT. Next slide, please. IMPACT is a physical activity intervention that we are currently evaluating in a type 2 hybrid effectiveness implementation trial. Briefly, IMPACT is offered to any youth between the ages of 5 to 18 years old with any cancer or blood disease diagnosis who are pre, on, or within 3 months of completing treatment at either Alberta Children's Hospital in Calgary or Stollery Children's Hospital in Edmonton. What does IMPACT look like? We offer online one-on-one physical activity sessions that are delivered by a qualified exercise professional. We meet with the children and adolescents up to 3 times per week, and each session ranges from 15 to 45 minutes for a total of 12 weeks. And we have that variability in there to really meet the child where they're at. The sessions are offered online so we can support them whether they are in the hospital or back at home. And the sessions focus on things like strength, balance, flexibility, core, cardio, everything within that session, but is individually tailored to how the child is feeling that day. Next slide, please. So what have I been up to this summer? I have been working on an interim analysis for this intervention. And specifically, we are using the REAIM evaluation framework to help guide us with our evaluation. So the objectives of the interim analysis were to examine implementation, and specifically we use the REAIM framework aspects of reach, adoption, and implementation. In terms of effectiveness, we were exploring select secondary effectiveness outcomes of participant-reported quality of life, as well as physical fitness. And the final objective, because this is a hybrid effectiveness implementation trial, we are conducting quality improvement cycles every 6 months, and that's to better understand some barriers and facilitators to the implementation of the intervention and trial. So we were interested and wanted to report on some of the changes and refinements that have been made. Next slide, please. So in terms of results, specifically with reach and adoption, the trial at this point in time that the analysis was conducted had been running for approximately 2 years. And we received 95 referrals, most of which had come directly from healthcare providers. However, we were only able to establish initial contact with only 36% of those caregivers who reached out to us. So that was a 39% recruitment upon initial contact. And so a lot of our quality improvement cycles has been centered around how can we improve that number. Of the 36 that we established contact with, we had 14 that expressed interest and enrolled, 12 of which completed the intervention, and 2 were currently in the intervention at the time of analysis. Next slide, please. In terms of implementation metrics, retention to the trial was 33%. I have the numbers listed there in terms of completion of outcomes. So that was specifically the questionnaires of quality of life and the physical functioning at baseline and post-intervention, so week 0 and week 12. In terms of adherence, so most children were attending approximately 2 sessions per week, but that did range from 0 to 3, and reasons for that depended on their treatment, side effects, as well as other commitments they had going on. And then we did have a high percentage of missing data related to the drop-off that we saw at the completion of post-intervention assessments. Next slide, please. And then some other implementation metrics to date with the 12 children who had completed, that had required over 115 training and delivery hours. In terms of fidelity, that was how closely the exercise professionals were following the protocol that was set for delivering the exercise. That was pretty high, and we had 0 major adverse events. Next slide, please. In terms of effectiveness, as you saw, we had a very small sample size, so likely not surprising that we weren't able to see any significance in our select secondary effectiveness outcomes. But as the trial continues on, we are going to be stopping recruitment in December, and once the trial is complete, we will fully take a look at the full results, including the primary effectiveness outcome of physical activity levels. Next slide, please. So where are we at with the interim analysis? We have submitted and worked on revisions to a special issue in the Children's Journal. And next steps will be including, once this is published, to develop a knowledge translation infographic. So this is an example of one from another study within our lab, but our lab is looking at ways that we can share this information with different end users beyond a manuscript itself. Next slide. And so with that, that's very brief of what I've been up to. I'm happy to take any questions at our block, and would like to thank the team involved behind this work, as well as our funding support. Thank you.
Thank you, Emma. Moving on, Rachel.
Hi, everyone. So my name is Rachel Hamilton. I'm a registered nurse at the Hospital for Sick Children, as well as a PhD student working with Dr. Lindsay Jibb. And today I'm excited to talk to you about my PhD work entitled Cancer Therapy De-Escalation: The Preferences of Parents of Children with Acute Lymphoblastic Leukemia. Next slide, please. When we talk about treating pediatric acute lymphoblastic leukemia, or ALL, we can't ignore the serious side effects that come along with its treatment. These therapies often hit kids hard, not just in the moment, but for years to come. The medications used can cause a wide array of side effects, including things like physical problems like nerve pain and bone damage, to cognitive and emotional challenges. Next. On average, kids who survive ALL end up dealing with more than 5 health conditions that stem from their cancer treatment, and over 3 of those are considered moderate to life-threatening. Compared to their siblings, these kids face a much higher risk of severe health issues. Next. Families and patients alike are clear. They want treatments that don't not only fight the cancer, but also reduce these harmful side effects as much as possible. Next slide. And next again. This has sparked a growing interest in what's called cancer therapy de-escalation. Essentially, it's about reducing the intensity or number of treatments to avoid causing unnecessary harm, but still making sure survival rates stay high. There's real evidence to support de-escalation, especially for kids with low-risk ALL. In fact, a successful trial was already done in 2021. By looking at each patient's disease biology and other personal factors, doctors may be able to develop gentler treatments for those with lower risk disease. But there are some risks to consider. Reducing treatment intensity could potentially lead to treatment failure, relapse, or even death. Because of the uncertainty, it can be a tough decision for families and patients to choose whether or not to go for de-escalated treatment or not. Next, and one more next. Oh, actually, can you go back? I guess my video is not working. That's why I plan on conducting a mixed method study to understand what matters most to parents making these decisions. This core tool I'll be using is called a discrete choice experiment, or a DCE. It presents parents with hypothetical treatment options and asks them to consider, help them choose and understand what trade-offs they're willing to make, like accepting slightly lower survival for fewer side effects. My work will first focus on developing and then administering a DCE like the one on the screen. A DCE is a research tool that helps us to see how people choose between two different options when they're presented with hypothetical scenarios. In the example you see on the screen, which was supposed to move through as a video with multiple options, you can see participants have to choose between two treatment options. Each option has a set of features like chance of survival or side effects, and each of those features vary in intensity. For instance, under nausea and vomiting, you might see levels like mild, moderate, or severe. The idea is to figure out what trade-offs people are willing to make. Are they okay with slightly less chance of survival if it means fewer side effects? Or is survival the most important no matter what? As the video would have continued, you'll see how participants go through this process, really thinking about what matters most to them. Overall, the goal here is to understand what parents prioritize when they're faced with tough treatment decisions. DCEs have been used a lot in healthcare for exactly this reason, and there's even potential to use them as a stepping stone to build future support for decision making, especially in the context of de-escalation. Next. My work will be completed across 4 phases. First, I have completed a scoping review to understand what's already known about decision-making in cancer therapy de-escalation across all ages and types of cancer. Next. Next, I will conduct qualitative interviews with parents who have participated in a de-escalation trial, as well as pediatric oncology clinicians. Using Sally Thorne's interpretive description, I'll analyze key descriptive decision-making factors, both practical and emotional. Next. Then those insights will inform the design and pilot of an electronically administered DCE survey to ensure it's comprehensive, and functions well from a functional point of view. Next. The final survey will be distributed to 250 to 300 parents via Momcology, a North American pediatric cancer-based advocacy network. We'll use statistical modeling to quantify which treatment attributes are most influential and how preferences differ based on different demographic factors. Next. Ultimately, this work will help us to build decision support tools for parents navigating de-escalated cancer therapy. As the pediatric oncology continues to move towards personalized and gentler treatments, understanding what matters most to families is critical. My goal is to make these incredibly difficult decisions a little clearer and a lot more supported. Thank you, and next. Thank you very much to my supervisor, my committee, as well as my funding sources, and I'll be happy to take any questions in our question and answer block. Thank you.
Thank you, Rachel. Haley?
My name is Haley, and I'm a summer student in the Sick Kids Summer Research Program in the Denberg Lab. My project is called What's the Catch? An evaluation of child-specific values in CDA approval of oncology therapeutics. Next slide, please. There is a large disparity in drug access between children and adults. Because the conditions children are diagnosed with are so rare, there's a small patient population to draw upon for clinical trials and weak market incentives to develop a drug for such a small group. Because there are few trials, there's limited evidence to prove therapeutic efficacy and safety, making approval of these drugs more difficult. This creates a positive feedback loop of there being few patients, leading to few trials and leading to less evidence, all compounding in fewer funded innovations for children and youth. Next slide, please. Once a drug does get approved for use, the process for it to be approved for funding is lengthy. Today, I'm going to be focusing on the health technology assessment step, which is done by Canada's Drug Agency. After a drug manufacturer makes a submission for review, a CDA committee will evaluate a drug's clinical and cost effectiveness, as well as input from patients and healthcare providers before deciding if they are going to recommend a drug to be reimbursed. Next slide, please. To understand how to resolve the pediatric problem, we look at this reimbursement step for drug access. Our study objective is to understand the decision factors informing reimbursement by examining whether and how pediatric factors are considered. Next slide, please. Firstly, I collected publicly available reports for drug submissions with pediatric indications over the past 15 years. Next, I extracted data pertaining to clinical trials and economic evaluations. And finally, using the in vivo software, I completed qualitative data extraction for a subset of pediatric oncology drugs in accordance with the CATCH framework. Next slide, please. CATCH is a value assessment framework for health technology assessment developed by members of the Denver Lab at SickKids. This framework is significant because it includes novel child-specific criteria, which I've bolded in this table over here, such as equity, family impacts, life course development, and fair share of life, which are not explicitly used in conventional health technology assessment. Next slide, please. So next I'll be sharing some of our preliminary results. 25 drugs with pediatric indications were found, 6 of which are oncology drugs. 22 were improved for reimbursement with conditions, and the prominent condition for reimbursement was price reduction. For 16 drugs, the implicit cost-effectiveness threshold of $50,000 per quality adjusted life year was surpassed, and you can see here how almost half of these drugs surpassed $200,000 per quality adjusted life year, demonstrating just how expensive they can be. Next slide, please. Through my data extraction, I was able to see how effectiveness, child-specific health-related quality of life, and family impacts were discussed most extensively, while life course development and fair share of life, which are the novel child-specific criteria, are discussed the least. Next slide, please. Equity was often discussed in terms of socioeconomic status of families, which also connects me to some of the family impacts that were included in the reports, which often included stress and anxiety surrounding the diagnosis and treatment, and especially the impacts on caregivers. Fair share of life and life course development were often shared in the clinician impact reports, where providers advocated for children to receive therapy to prolong their lives and adequate treatment while growing to ensure that they grow up to become healthy adults. Next slide, please. From this study, we have learned how a child-tailored value assessment framework may contribute to a more comprehensive evaluation of pediatric therapies through considering unique value-based criteria. This has potential downstream impacts for funding and access. Next slide, please. To conclude, I wanted to discuss the bigger picture of this type of research. When I was reading through a patient input report, I came across this submission from a mother, which included photos of her daughter who had immensely improved quality of life because of one of the drugs she had been taking. At the surface, studying these types of reports may seem insignificant, but this submission reminds us how important it is to understand reimbursement decisions as they directly impact children like this. Thank you so much for listening, and I'm happy to take any questions at the end of my presentation or all the presentations in this block.
Thank you, Haley. On to the next speaker. On the next slide is Amy.
Hi, everyone. My name is Amy, and I'm a medical student doing research at SickKids this summer with Dr. Paul Sumit Gupta and Dr. Paul Nathan. And our project is looking at late effects in survivors of a rare cancer called pediatric Langerhans cell histiocytosis, or LCH for short. Next slide, please. So Langerhans cell histiocytosis is a rare neoplasm of myeloid precursor cells, so immature blood cells that start in the bone marrow, and they form infiltrative lesions that can go to any organ system in the body, but most often the bone, skin, and pituitary gland. It's a childhood cancer primarily. The mean age of diagnosis is 3 years old, although it can occur at any age. And so survivorship is really important in LCH because it could be as low as 60% for multi-system LCH with risk organ involvement. These are organs that have been found to be associated with a higher risk of mortality. However, this is a minority of cases. Most cases actually have relatively high survivor rates with close to 100% for single system LCH, for example. And so it's really important to understand the late effects for survivors. These are consequences from diseases, from LCH itself, from the disease, or from treatment. And these late effects could be physical. So for example, risk of having a heart attack later in life, could be psychological. So for example, mental health care use, or it could be functional. So for example, hearing aid use. Next slide, please. And so the main goal of my work this summer has been to describe the incidence of physical, psychological, and functional late effects experienced by survivors of pediatric LCH compared to healthy controls. And how are we going to do this? Next slide. Thank you. Okay, so we're doing a matched retrospective cohort study using health administrative data from ACCESS. ACCESS is a really wonderful organization in Ontario that uses any routinely collected administrative data and allows researchers to connect them all using de-identified keys so that we can collect lots of information and do these large population-based studies. So we are identifying childhood LCH survivors using a particular childhood cancer database. And so we're looking at all survivors from 1986 to 2019. So I have that here as the orange smiley faces, and we're matching them 5-to-1, which I have as the blue smiley faces below, to healthy controls, people who are matched on age, sex, and location, but have never had cancer before. We're following them forward in time to evaluate the incidence of physical, psychological, and functional late effects. So, for example, among survivors, in this example I have here, 50% of them had the particular outcome we're looking for, whereas among controls, only 30%. And so this data is still ongoing, but we're going to look at the incidence of these particular late effects to try to better understand what survivors can expect in the future. Next slide, please. So the implications of this kind of work is twofold. First, for health system planning, and secondly, for survivorship care. So kind of like I alluded to, health system planning and understanding what may happen in the future or what the risks are for certain survivors of LCH can help us perhaps put screening programs in place for certain diseases or have resources in place ready for survivors as they transition into adulthood and continue on in life. And it's also really important for survivors themselves to have an understanding of what to look for in their own bodies and take control of their own healthcare journey, as well as for the healthcare teams caring for them to understand how to do that in the best way. Thank you so much.
Thank you, Amy. Now moving on to Georgia.
Hello, everyone. I'm Georgia from the University of Calgary's Thrive Lab, and today I'm going to be presenting on my ongoing scoping review on transdiagnostic interventions. Next slide, please. Childhood cancer survivors often experience symptoms that occur together and they make each other worse. These symptoms can include anxiety, depression, fatigue, and pain. They often have to seek care in multiple places to address their symptoms, making treatment less accessible, time-consuming, and costly. Transdiagnostic interventions offer an effective and efficient approach to address this by targeting multiple symptoms at the same time. We are hoping to develop a transdiagnostic intervention for childhood cancer survivors, and to inform that process, we need to understand the current state of the field by conducting a scoping review. Next slide, please. The objective of this review is to map the extent and nature of empirical research using transdiagnostic interventions in oncology populations across the lifespan and disease trajectory. Next slide, please. We followed Arkesky and O'Malley's framework for scoping reviews, which is outlined in 6 steps. This is a widely used framework for scoping reviews. Next slide, please. Article inclusion criteria was empirical studies published in English that examined interventions addressing 2 or more mental and/or physical symptoms in oncology populations. And our exclusion criteria was gray literature and non-original research and intervention protocols without a psychology-based component. Next slide, please. So our Prisma diagram is laid out here. We had 2 independent reviewers and they screened 6,971 articles at the title and abstract level, and a 3rd reviewer resolved conflicts. 34 studies were screened at the full text level, and 10 studies were included in data extraction. Next slide, please. Of the 10 studies included, 7 were of distinct interventions. All studies were published in the last 10 years, which indicates that this is a fairly new field. All studies were conducted in adult populations. Interventions were primarily delivered as web-based, except one intervention, which was delivered as a hybrid and included 2 face-to-face sessions and 1 DVD delivered session. Interventions predominantly targeted anxiety and depression together. However, interventions also targeted anxiety, depression, and fear of recurrence, anxiety, depression, insomnia, sexual dysfunction, and health-related quality of life, and worry, sleep difficulties, depression, and fatigue. Additionally, 57% of the interventions engaged patients in the development process. Next slide, please. The results of the study highlighted 3 key points. As mentioned, studies were published in the last 10 years, and there was no date criteria set for this review. This really tells us that this is a newer field. Second, all the studies were conducted in adult populations, highlighting the gap in the literature and demonstrating a need for transdiagnostic interventions for the use of pediatric oncology populations. And finally, the findings of this review have shed light on transdiagnostic interventions in oncology populations and will help to inform the development of a novel transdiagnostic intervention for childhood cancer survivors. Next slide, please. Finally, I just want to thank all who contributed to this project and to ACCESS for giving me a platform to share my work. Thank you so much.
Hello, my name is Isla, and I'm a summer student in the Care for Kids lab at the University of Calgary. My project is in the field of psychosocial oncology, and it's exploring the relationship between family functioning and social adjustment in pediatric acute lymphoblastic leukemia, or ALL, survivors. For context, pediatric ALL survivorship has been exponentially increasing due to advances in modern treatments. As a result, more survivors are facing late effects. Specifically, ALL survivors experience the psychosocial late effect of poorer social adjustment, which means that survivors struggle to develop socially in accordance with their age. Currently, literature on ALL has linked family functioning to several positive survivor outcomes, yet the relationship of family functioning and social adjustment remains uncharacterized in this population. So the aim of my project was to explore this critical research gap. Next slide, please. To do this, we recruited pediatric ALL and non-CNS solid tumor survivors from the Alberta Children's Hospital Long-Term Survivor Clinic. Survivor families completed the Family Environment Scale, or FES, and the Patient Reported Outcomes Measurement Information System, also known as PROMIS, which was a parent depression self-report. Both the FES and PROMIS were used as measures of family functioning. To measure social adjustment, I used the withdrawal subscale from the 3rd edition of the Behavioral Assessment System for Children. And then for data analysis, both a permutational multivariate analysis of variance and Pearson's correlations were conducted to quantify differences in family functioning between groups and to see the relationship between family functioning and withdrawal, respectively. Next slide, please. The FES is made up of 10 subscales, so when we only consider the FES in our model for family functioning, we find that group diagnosis accounts for 5.1% of the overall difference in survivor family functioning. Moreover, out of all 10 subscales, we see that only the FES conflict and control subscales significantly differ between the 2 groups. Next slide, please. So in light of these findings, I expanded my model for family functioning by adding the PROMIS Parent Depression Self-Report. I also removed all insignificant FES scales from the analysis, restricting the updated model to only include FES conflict and control. When the PERMANOVA was ran again on the updated model, we now see that family environment accounts for 15.7% of the overall difference in survivor family functioning. Next slide, please. In terms of social adjustment, we saw that the Basque withdrawal scores did not have any relationship with family environment for ALL survivors in either model. However, in solid tumor participants, we saw that family functioning and social adjustment had a significant relationship in both models. For example, in the preliminary FES-only model, Basque withdrawal scores had a significant negative correlation with the FES intellectual cultural orientation, active recreation, moral religious emphasis, and organization subscales. In the updated model, the Basque withdrawal scores were significantly associated with FES control and the promised parent depression scores. Next slide, please. Overall, we see that family functioning differs based on survivor diagnosis, with more adaptive functioning being associated with better solid tumor survivor social adjustment. While ALL family environment and child social adjustment did not correlate, family-focused interventions may still mitigate group differences and improve other ALL outcomes, such as child depression. Further studies should examine other factors that contribute to ALL social adjustment, such as treatment intensity, so that we can inform better interventions to better support survivors. Thank you.
Thank you very much. And now for Lauren.
Hi everyone, my name is Lauren Ung and I'm a second-year medical student at the University of British Columbia. And I've been working this summer on a quality improvement study with Dr. Rebecca Dayel out of BC Children's Hospital here in Vancouver. And my project is titled Abdominal Mass Virtual Huddle. It is a quality improvement initiative and we're trying to optimize diagnostic tissue adequacy in pediatric abdominal tumors. So for some background information, abdominal solid malignancies represent a significant disease burden in the pediatric population, and the most common types, which include neuroblastoma, Wilms tumor, and hepatoblastoma, they actually account for 10% of all childhood cancers. And as many of you know, accurate tissue diagnosis is very critical for the initiation of treatment, molecular characterization, and also research participation. So the problem, we have two methods of biopsy. There's open biopsy, which is done by a general surgeon, and then we have core needle biopsy, which is done by the interventional radiologist. And traditionally, open biopsy has been the preferred and standard method for tissue biopsy for these types of tumors. However, we've been seeing open biopsy having higher mortality and morbidity rates for pediatric abdominal tumors. And more recently, core needle biopsy, or CNB, has been increasingly widespread and used, especially at our hospital here. However, it is unclear if core needle biopsy compromises the rate of diagnostic tissue adequacy. So our aim of this project is to try to improve the overall diagnostic tissue adequacy rate by more than 20% from baseline from the pre-intervention data that we have for pediatric patients that have been newly diagnosed with abdominal tumors at British Columbia Children's Hospital by implementing the virtual huddle process. And before I go into the virtual huddle process, I just want to define what we mean by adequate tissue. So this means tissue that is sufficient to achieve timely diagnosis with molecular characterization, facilitate participation in research studies, and also provide at least one vial of fresh frozen tissue for future use. So for my methods, for our pre-intervention data, we wanted to do a retrospective chart analysis of patients who presented at BC Children's from 2020 to 2024, who presented with an abdominal solid tumor. And then in October of 2024, this intervention was initiated. So as you can see here, this is a good review of kind of the flow of when a new abdominal mass is presented. So the new abdominal mass is presented and usually the oncologist is consulted. There's cross-sectional imaging done, usually a CT or MRI, and then general surgery is consulted. So the virtual huddle was triggered if the general surgeon suggested that actually the core needle biopsy may be a better method for this type of tumor, this patient, this case. And then the abdo biopsy virtual huddle included the general surgeon, the pathologist, the oncologist, and the interventional radiologist, and they would come together and discuss the case and then ultimately decide which would be better, the open biopsy or the core needle biopsy. So we have some preliminary results. So as you remember, we did the pre-intervention data analysis, and out of those 43 pre-intervention patients, the tissue adequacy rate was 77%. Post-intervention, although we've only had 10 patients so far since the intervention was implemented, our tissue adequacy rate is now 90%. Which is improvement so far. More importantly, we also have seen no complications so far post-intervention, whereas pre-intervention, we had about a 20% complication rate for the open biopsy and a 10% complication rate for the core needle biopsy. So although the results are preliminary, we can see that this virtual huddle is a feasible way for planning core needle biopsy procedures. And it also has enhanced multidisciplinary communication around the tissue needs, addressing not only the diagnostic requirements, but also research and molecular testing goals. And so, in conclusion, continuous improvement is still being pursued by seeking and providing outcome feedback to the involved physicians, and we're still collecting data for post-intervention, which is really exciting. And then I would just like to acknowledge the DAL research team for helping me with this project, as well as the UBC Faculty of Medicine Summer Student Research Program, which has funded this project. Thank you.
Thank you, Lauren. Moving on to Rachel.
Hello, my name's Rachel Taylor, and I'm a summer student at the Care for Kids Lab at the University of Calgary. And this summer, my project looked at the impact of physical activity and sleep quality on mental health outcomes in childhood cancer survivors. So for some background, as we know, the survival rate for childhood cancers are increasing, but this also means that there are more survivors at risk for the late effects of cancer and its treatment. So previous research has suggested that lifestyle behaviors may be able to mitigate the risk of late effects, but the association between specific lifestyle factors, such as physical activity and sleep, and mental health outcomes is not yet well understood. So we wanted to determine the prevalence of healthy lifestyle behaviors and mental health outcomes in childhood cancer survivors, and then determine if there was an association between specific lifestyle behaviors and mental health outcomes. Next slide, please. And so for this analysis, we used a sample of 312 childhood cancer survivors from the Long-Term Survivor Clinic at Alberta Children's Hospital. And these survivors completed a self-report questionnaire assessing both their lifestyle behaviors and the late effects they experienced. And what we saw was that the prevalence of sufficient physical activity was about 60.6% in our participants, which is similar to that of the general population. And then in terms of mental health outcomes, 33.5% of participants reported fear of cancer recurrence, 43.3% reported anxiety symptoms, and 29.2% reported depressive symptoms. So this suggests that survivors may be experiencing more mental health issues than non-cancer survivors, as this is higher than what we would expect in the general population. And so next, we wanted to look at the association between physical activity and mental health outcomes. And so using a multiple binary logistic regression model accounting for potential confounders, we saw that physical activity was not significantly associated with fear of cancer occurrence, anxiety, or depression. Next slide. And then we wanted to investigate sleep quality. And so in our study population, 75.7% of participants reported sufficient sleep quality, which is slightly lower than that of the general population. And then in contrast to physical activity, sleep quality was significantly associated with mental health outcomes in our multiple binary logistic regression model. So sufficient sleep quality decreased the odds of reporting fear of cancer occurrence by 67%, anxiety symptoms by 84.5%, and depressive symptoms by 89.3%. Next slide. And so overall, we saw that sufficient sleep quality is associated with decreased odds of reporting mental health outcomes, while physical activity is not. And this suggests that certain lifestyle behaviors may help to improve the mental health outcomes of childhood cancer survivors. However, the cross-sectional nature of our study prevents us from determining the directionality of these associations, so we cannot infer these causal relationships. Future research should further investigate this association to elucidate both the directionality and the pathways by which lifestyle and mental health are associated in the context of childhood cancer survivors. And this would help us understand if lifestyle changes can alter mental health outcomes or vice versa. And ultimately, this would help clinicians provide accurate and informed recommendations to their patients to help them achieve the best quality of life possible through their survivorship journey. Thank you.
Thank you, Rachel. And now Chaoran.
Yes. Hi everyone, I'm Charan from University of Toronto. Today I'm going to present my research on estimating the economic impact of reducing geographic disparities in pediatric cancer care. Next slide, please. Before I start, I want to first acknowledge that this research has received funding support from the institutions listed here. Next slide, please. Currently in Ontario, there are 5 tertiary hospitals that provide pediatric cancer care, and all of them are located in urban areas. As a result, families living in the rural and remote areas, they are faced with longer travel time, higher travel costs, and are more likely to miss days of work. To address that, the Pediatric Oncology Group of Ontario, or POGO, launched a satellite program which established 8 satellite centers across Ontario, as shown as the blue dots in the map here, to provide pediatric cancer care closer to home. And the objective of our study is to assess the impact of the program in reducing the geographic disparities and family economic burden. Next slide, please. To achieve that, we use a retrospective cohort design and compare the outcomes between 2 scenarios. In one scenario, we capture the patient's actual visits to the satellite center and compare it with a hypothetical scenario where we assume that the satellite centers do not exist, and patients instead visited their tertiary hospital of referral. For this study, we identified patients under 18 years old with a cancer diagnosis between 2018 and 2023 who had visited a satellite center before. We geocoded patients' residence to estimate their drive time and distance from their home address to the facility. We also calculated the cost, which included transportation, hotel, income loss, and childcare for additional siblings. As for the statistical analysis, we conducted both descriptive analysis and generalized estimation equations. Next slide, please. As for the results, we identified 843 patients in total with a mean of 34 satellite visits. When comparing with patients who had never used the satellite centers before, we found that the satellite cohort had a higher proportion of leukemia lymphoma cases, similar rural remote representation, and a lower proportion of households coming from the most socioeconomically disadvantaged areas. Next slide, please. As for the outcome, visiting a satellite center instead of a tertiary hospital saved around an hour and $56 for each visit, totaling up to $1,600 for each household. And most of the cost savings were coming from indirect costs, such as income loss. Next slide, please. And here is a map showing the cost distribution for these 2 scenarios. From this map, we can see that there was a province-wide cost reduction with the addition of satellite centers in place. However, for families living in Northern Ontario, even with satellite centers established, they are still faced with high economic burden in accessing their pediatric cancer care. Next slide, please. This plot shows the regression results, and the results showed that for families living in the suburban or rural remote areas, as well as those coming from the more marginalized neighborhoods, they could save more cost from satellite center visits, and some could even reach around $300 for each visit. Next slide, please. There are several limitations for our study. First, it is assumption heavy, as we may not fully reflect the real world behavior. Ecological fallacy exists, as we use area level data to represent individual characteristics. We also didn't capture certain cost categories, such as parking and food. Next slide, please. In conclusion, the satellite program reduces travel time and cost for families of children with cancer, especially for those living in the suburban, rural, remote, or lower socioeconomic status areas. However, these regions remain underserved, which indicates that targeted strategies could be helpful for this population. Similar programs as the satellites program may be justified in other jurisdictions. And thank you. That's all for my presentation today.
Thank you, Sharon. So now next slide.
Hi everyone, my name's Ellie, and today I'll share with you more about my project targeting mitochondrial antioxidant response in pediatric sarcomas. And I've been working on this project in Dr. Sorensen's lab in the BC Cancer Research Institute. Next slide, please. So I'm studying osteosarcoma, which is the most common type of bone cancer and is primarily found in adolescent patients. This is also the cancer that Terry Fox had, as a historical aside. So osteosarcoma is treated with surgery, chemotherapy, and radiation. All of these treatments can have really harsh side effects for pediatric patients, as we've heard in previous presentations. So the 5-year survival rate for localized osteosarcoma is about 70%. However, that drops significantly to 20% for patients with metastatic disease. Now, the most common site of osteosarcoma metastasis is the lung, as you can see here in the cartoon below. And unfortunately, there's been no improvement in patient outcomes with metastatic osteosarcoma in decades. And this really emphasizes the importance of identifying novel therapies to combat this disease. Next slide, please. This brings me to our project. So we're evaluating theostreptin, and this is a bacterial-derived antibiotic that has been tested in numerous preclinical and clinical cancer studies, all focused on adult cancers though. So what we're aiming to do is to produce a preclinical data set that supports the use of theostreptin in treating pediatric osteosarcoma lung metastasis. So we've done numerous assays to date in the Petri dish, confirming that this drug halts the growth of metastatic osteosarcoma cells and even kills them. So I'll be sharing with you 2 additional assays that really show the potential this drug has. Next slide, please. The first one that I'll be sharing with you is called the pulmonary metastasis assay. And this assay was the first step that we took towards testing the drug in a more physiologically relevant setting. So to tell you a little bit more about the assay, it involves the injection of human metastatic osteosarcoma cells into mice. And these cells glow fluorescent green, so we can easily visualize them using fluorescent microscopy. These cells then travel up to the mouse lungs and colonize them, as we would expect to see in metastatic osteosarcoma. Following, we euthanize the mice and we obtain thin lung sections, which we treat with our drug to see again if it has an effect in decreasing the lung tumor burden. And we visualize this using fluorescent microscopy. Next slide, please. And this is what our data looks like. So on the left-hand side, you can see the 2 cell lines that we used, MNNG and MG63.3. And at the top, you can see the different amounts of drug that we used to treat the lung slices. And you can see in both cell lines, but more so in the MNNG, that there is a decrease in the amount of green fluorescence that we see, indicative of the fact that the drug does indeed decrease the amount of lung tumor burden that we see. And that's promising because, again, it is in a more physiologically relevant setting. Next slide, please. The next assay I would like to share with you is about treatment combinations. So theostreptin and a commonly used therapeutic in metastatic osteosarcoma. And this is particularly important in our case because the theostreptin is unlikely to be used alone to treat metastatic osteosarcoma, and it's more likely to be used in combination with, again, a commonly used therapeutic. So in this case, we chose etoposide because it's a chemotherapeutic agent used in the clinic to treat metastatic osteosarcoma. And what you can see in the red boxes is that when we treat cells using theostreptin and etoposide together, we see a decreased cell viability, which indicates that the 2 work together really well in combating metastatic osteosarcoma in the Petri dish. Now, thinking further about this in a more clinical setting, what this could mean is that we can use lower amounts of etoposide to get the same therapeutic effect. And that, again, can be an improvement for pediatric patients and their side effects. Next slide, please. So I shared with you two important assays that we've done in recent weeks. And if you have any further questions, I'd be happy to answer. And a big thank you to my PI, Paul Sorensen, and the staff scientists I've been working with, Dr. Michael Lizardo.
Ellie, thank you so much. Moving on to the next speaker, Simran.
Hi everyone, my name's Simran. I'm a master's student at the University of Calgary in the Care for Kids lab, and my project's based on implementing distress screening in pediatric oncology care at the Alberta Children's Hospital. So I want you to imagine being a child diagnosed with cancer, facing painful procedures, hospital stays, and an uncertain future. Yet no one ever asks about the symptoms associated with distress that you endure every day. Distress, as defined by the National Comprehensive Cancer Network, is a multifactorial, unpleasant experience of a psychological, social, spiritual, and/or physical nature that may interfere with the ability to cope effectively with cancer, its physical symptoms, and its treatment. In many pediatric oncology clinics, associated symptoms like fatigue, pain, nausea, mouth sores, and worry remain unmeasured, unscreened, and therefore unmanaged. My research aims to change that by embedding the Symptom Screening in Pediatric Tool, or SPEEDY, a 15-item questionnaire that enables systematic screening for the most burdensome cancer-related symptoms into routine care at the Alberta Children's Hospital so that distress burden can be recognized early and addressed promptly. We hypothesize that routine speedy screening will detect significant symptoms of distress sooner, trigger earlier symptom-directed referrals such as pain management, nutrition, or psychology, and ultimately improve quality of life and treatment adherence for young patients and their caregivers. To pursue these aims, we have already completed a scoping review of pediatric symptom measures and selected SPEEDY for its strong psychometric properties, child-friendly design, and appropriateness for clinical integration. And this was done in consultation with members of the ACCESS network. Next, we are assessing organizational readiness, so interviewing clinicians about comfort, workflow impact, and perceived barriers, and also surveying families about their experiences with current symptom management. Building on these insights, we will conduct a small-scale pilot in our hospital at home oncology program. SPEEDY will be integrated into the EMR, into EPIC, and enable children in the home-based care arm to complete the tool before visits. A comparable group receiving standard care without symptom screening will serve as a control. Throughout the pilot, we will conduct qualitative interview data and receive qualitative interview data from clinicians and caregivers, which will be guided by the Consolidated Framework for Implementation Research. We will also conduct and collect SPEEDY scores, alert frequency, and the type and timing of referrals generated. Our analysis will focus on feasibility and acceptability, which means we will collect and try to understand completion rates, time burden, and user feedback, the degree of workflow integration, which will be measured by the proportion of visits with documented SPEEDY scores, as well as clinical impact assessed by the interval from symptom onset as identified through SPEEDY to appropriate referrals compared with the control group. Should major barriers emerge, the implementation strategy will be refined before wider rollout. By making symptom burden visible, routine SPEEDY screening promises to prevent children from falling through the cracks. Ultimately, we are working to scale this model across the National ACCESS Pediatric Oncology Network, ensuring that no child fights both cancer and unmanaged distress alone. Thank you.
Thank you, Simran. Moving on to the next presenter, Julia.
Yes, hi. So I'll be talking about part of my PhD project, which is modulating mitochondrial proteins as a treatment strategy in ETP-ALL. Next slide, please. So I'll start off with a bit of background. I'm sure all of you know ALL is a very common pediatric cancer, and it's divided into two main subtypes, BALL and TALL. And within TALL, there's several subtypes, and my project focuses on the early T-cell precursor subtype, mainly because at this time it's characterized as a higher risk subtype because it has higher rates of induction failure, which then leads to inferior long-term survival. I'm highlighting the need for like more tailored therapies for ETPLL because at this time it's treated as any other TLL, but they've been shown to be metabolically different. And so here there was a CRISPR screen that was done on the Kudel3 cell line, which is derived from a pediatric ETPLL relapsed patient, and that found that two mitochondrial proteins that are mainly involved in mitochondrial fusion and mitochondrial dynamics that could be good potential targets because they were actually essential for the cell line's survival. Next slide, please. And so what I've been working on this summer is basically validating the target using a pharmacological agent. So then I looked at, I extracted the RNA, ran RNA sequencing, and then analyzed and validated the data to kind of identify the mechanism behind this dependency. Next slide, please. And so I first of all treated the Kudel3 cell line with an inhibitor of MFN2, which is called MFI8. So I confirmed that the cells were actually sensitive to this inhibitor. And I looked at also different patient samples. So CUL 157 and 292 are actually patient samples that I injected into mice. Then I collected the cells and treated them. And so in all, in the Kudel3 cell line, as well as the two patient samples, I found that following the treatment, I found an increase in apoptotic cells, which was encouraging. So you can move on to the next slide. So then I extracted the RNA, did the RNA sequencing just to kind of see what the mechanism behind this inhibition was causing the cell death, because it's an inhibitor that's not very well characterized at this time. So there's obviously a lot going on. If you look at panel A, there's about close to 10,000 genes that are differentially expressed. And so to kind of help us figure what was going on, we did a gene set enrichment analysis. So that kind of helps us sort these genes that are differentially expressed into like the pathways that they're involved in. And so I found that there is a significant amount of genes that are involved in the unfolded protein response that are upregulated. And then I also found that translation was dramatically downregulated. And so this led us to our hypothesis that what was happening is that because MFN2 is very important in the tethering of the mitochondria to the ER, we're actually impacting calcium flux that's going from the ER to the mitochondria, which then releases calcium into the cells and then creates a stress response. Next slide, please. And so this is what we actually showed. And so we measured intracellular calcium using calcium orange, and then which is a calcium indicator. So in flow cytometry, we stained the cells and we were able to quantify the calcium levels. And so following the treatment, I have a significant increase in calcium levels. And I also, so this confirmed that we had a calcium imbalance. And then to look at if I had the ER stress, which is the unfolded protein response, we were able to we have a dye that binds to the free thiols on misfolded proteins, which is TPMI in panel B. So here we show that there's an increase in free thiols, which is indicative of an increase of misfolded proteins. And then a very common marker of ER stress is HSP70 or heat shock protein 70. And so I looked at via Western blot, I looked at the increase, and I found about a 35% increase in this level of protein indicative of ER stress. Next slide, please. And so this is obviously a very small part of my PhD project. I have a lot of things to go over still. So there's a lot going on with MFN2 inhibition. So my goal is to validate the other impacts that we're seeing. I also am working on testing the effect of my inhibitor on leukemia progression in vivo in mice, so in different patient samples as well, to see if it could be implemented in the clinic eventually. And so if it could be used in clinical trials. And also I'm looking at using it in combination with currently approved therapies that are used to kind of diminish the use of chemotherapies. So thank you to all of my lab members and ACCESS for allowing me to present my work today.
Thank you, Juliet. Moving on to the next speaker, who is Matthew.
Hello, everybody, and thank you, Juliet, for that nice segue into my project. So my name is Matthew Temple, and I'm a master's student in the Tremblay Lab in the Immunology Department at the University of Manitoba. My project explores how T-cell acute lymphoblastic leukemia resists chemotherapy by inducing a stress response that can alter metabolic pathways. And by doing this, I hope to identify novel therapeutic targets. Next slide, please. Chemotherapy for T-cell acute lymphoblastic leukemia, or T-ALL, is limited to a combination therapy of vincristine, dexamethasone, and L-asparaginase, or VXL for short. And they can also include anthracyclines such as doxorubicin. These drugs, especially anthracyclines, have very high levels of toxicity, and they can eliminate leukemia, but this comes at the cost of lifelong impairments, both physical and psychological. Despite these high costs of chemotherapy, about 30% of patients relapse after going into remission, and 20% of patients don't even respond to therapy. Having only this one therapy regimen limits the overall long-term survival to about 50%. Thus, the development of novel therapies is crucial. Next slide, please. Due to the complications associated with studying T-ALL in human patients, we utilize a mouse model. We transplant bone marrow samples from T-ALL patients into sublethally irradiated, immunocompromised NSG mice. The human T-ALL is able to engraft in the mouse's bone marrow and spleen, and then proliferate and disseminate throughout the rest of the body, causing the mice to develop overt leukemia. Once leukemia reaches a high enough proportion in the blood, we treat the mice with VXL chemotherapy, euthanize them, then harvest their bone marrow and spleens. Next slide. Leukemia requires large amounts of nutrients to proliferate so extensively. This causes T-ALL cells to have a distinct metabolic profile from other healthy cells in the same mice. The metabolic profile is largely controlled by a protein called mTOR, which serves as a master regulator of metabolism. mTOR affects metabolism and cell growth largely through its control on protein synthesis and the activation state of various metabolic pathways. For protein synthesis to occur, mTOR must phosphorylate the ribosomal protein S6. And so to detect the onset of a stress response, I analyze the amount of S6 phosphorylation in the bone marrow and spleen samples via flow cytometry. A stress response is induced at early time points by chemotherapy within an hour to 4 hours. And it first remodels and then shuts down different metabolic pathways. Since VXL chemotherapy targets many aspects of metabolism, such as protein synthesis, it seems logical that T-ALL cells must alter their metabolism to evade chemotherapy. If we can understand the stress response induced by chemotherapy and how it influences the metabolism of cells, we can propose novel druggable targets that can be exploited to sensitize T-ALL to existing chemotherapy or develop novel therapies. Thank you all for listening, and I'll be happy to take any questions. We can skip the last slide.
Thank you, Matthew. The next presentation is from Alicia.
Hi, everyone. My name is Alicia Kilfoy. I'm a registered nurse in the hematology and oncology program at the Hospital for Sick Children and a PhD candidate at the University of Toronto under the supervision of Dr. Lindsay Jibb. And my PhD thesis is entitled Co-Design of a Resilience Promoting Health Intervention for Parents of Adolescents with Acute Lymphoblastic Leukemia or ALL. Next slide. So adolescents with ALL, historically those aged 13 to 18 years of age, face unique psychosocial challenges throughout their cancer treatment due to their age, developmental stage, and high risk for relapse disease status. These challenges include but aren't limited to the fact this population has to grow and maintain a level of autonomy, independence, and disease self-management skills, while also navigating concerns around education, intimacy, relationships, and fertility. For parents of adolescents with ALL, supporting their child through these developmental concerns while also quickly becoming a primary caregiver for a very sick child has been cited in the literature as being extremely challenging. These challenges are further compounded by the fact that the population has reported in the literature feeling under-supported by their child's clinical team. Together, this clinical picture has significant psychosocial impact, with parents of adolescents with ALL reporting high levels of psychosocial distress, anxiety, depression, and overall low levels of quality of life. Resilience is a positive psychosocial construct, which can be defined as the process of adapting well in the face of stress or adversity. The construct has shown to be important in pediatric oncology, with parents with higher levels of resilience showing lower levels of anxiety, distress, fatigue, and improved quality of life compared to parents with lower levels of resilience. There are currently a number of resilience-promoting interventions available specifically for parents of children with cancer. However, there are several limitations and concerns to the current interventions available, which I just want to highlight. First, they're very infrequently tailored to parents of specific age groups or parents of specific diagnoses, and this tailoring approach has really been shown in the literature to improve overall effectiveness and sustainability of psychosocial interventions. Further, resilience-promoting interventions are frequently offered in person, which has been shown in the literature and cited and explained by parents as decreasing the accessibility of these types of interventions. And then lastly, the interventions themselves are infrequently designed alongside parents, a process known as co-design, which really limits the process of incorporating parental needs and preferences into the interventions themselves. Next slide. So to address this gap, my PhD thesis is focused on co-designing a tailored resilience-promoting mobile health intervention or mHealth intervention specifically for parents of adolescents with ALL. And the intervention itself will be a mobile app that's entitled Integrated Support for Parent Resilience or INSPIRE. To co-design INSPIRE, I plan to use a multi-phase, multi-methods approach. The first phase one, is a needs assessment where I plan to interview both interdisciplinary clinicians, approximately 6 to 10, and approximately 20 to 25 parents of adolescents with ALL to really determine the necessary resiliency promoting skills to incorporate into INSPIRE. I then plan to take the promoting skills I identified in phase one into phase two, which will involve a series of focus groups, approximately 4, with parents of adolescents with ALL that are moderated by myself, a parent with lived experience, and a digital health expert, where we will prioritize the skills identified in phase one and co-design a digital prototype of INSPIRE. I then plan to take that digital prototype into phase 3, where I'll complete 3 cycles of mixed methods usability testing. So specifically, parents will be asked to work through the digital prototype of INSPIRE and think aloud about their experiences, and then they'll participate in a semi-structured interview and complete a quantitative survey. Ultimately, this process will help us iteratively refine the digital prototype of INSPIRE so that we can create a high fidelity prototype ready for effectiveness testing. Next slide. So ultimately, my PhD work is aiming to create a diagnosis and age-specific intervention for an under-researched and under-supported population, which will be ready for effectiveness testing, and I'm hopeful that that would be the focus of my postdoctoral work. My work is aiming to address a pressing gap in the care of Canadian childhood cancer families, and if shown to be effective, this intervention has the potential to decrease the long-term psychosocial consequences of a cancer diagnosis for parents of adolescents with ALL and improve the quality of life in these families. Next slide. So just a quick acknowledgement slide to my amazing supervisor, committee members, and a really special shout out to our parent partners from Sick Kids RFAC and OPAC, particularly Megan Easton, and our varying funding sources from CIHR and Leukemia and Lymphoma Society. Thanks so much.
Wonderful. Hi, everyone, and good afternoon. My name is Gabriella, and I'm a second-year medical student at the University of Manitoba. Today, I'll be presenting an overview of my study on understanding and advancing survivorship care for childhood cancer survivors in Canada. Next slide, please. So, as we've discussed, the population of childhood cancer survivors in Canada is not only growing in size, but also advancing in age. And while mortality rates are promising, morbidity rates are not. Next slide. Childhood cancer survivors often face late effects from their cancer and its treatment. In fact, over 40% of childhood cancer survivors experience a severe, life-threatening, disabling, or fatal late effect. They can include psychosocial effects like anxiety, unemployment, or interpersonal issues, physical effects, including cardiac, renal, or endocrine issues, chronic conditions like hypertension and diabetes, or recurrences in new cancers. So, childhood cancer survivors require lifelong, quality survivorship care to monitor and address the late effects of their cancer and its treatment. Next slide, please. So, our study has two objectives. First, we want to evaluate survivorship care practices for childhood cancer survivors. And second, we want to use our results to develop the Canadian Survivorship Care and Advocacy Network, which I'll refer to as CanScan. Our goal is that this network will advocate for consistent, person-centered, evidence-informed survivorship care, regardless of where a survivor lives. Next slide. So our study is taking a mixed methods approach composed of surveys, interviews, and focus groups to hear from three cohorts. First, being healthcare providers across different roles, including physicians, registered nurses, nurse practitioners, psychologists, and social workers at the 17 pediatric cancer centers across Canada. As well, we're listening to survivors and their caregivers. Next slide. So recruiting healthcare providers to our study is simple because their contact information is easily accessible online. Recruiting survivors and caregivers presents a greater challenge, especially because we're working on a national scale. We've decided to refer survivors and caregivers to our study using social media platforms and mailing lists of partner organizations like Childhood Cancer Canada and ACCESS that are national, but also regional organizations like Kids Cancer Care. As well, we are displaying our recruitment posters at survivorship care clinics across the country, which does require ethics approval at those sites. Next slide, please. To fully appreciate the experiences of our participants, we're talking to 2 to 4 healthcare providers per center in a semi-structured interview. One healthcare provider will be identified based off of their leadership position at their clinic and identified as a key respondent. They'll complete a survey on their survivorship clinic structure. As well, survivors and caregivers will be asked to complete a survey on their cancer treatment, survivorship care, and their access to support services. Then each will share their experiences over 2 focus groups. Next slide. Our survey data will be summarized using descriptive analysis, and our interviews and focus group transcripts will be analyzed using a framework analysis. Healthcare providers, survivors, and caregivers will be asked in their surveys if they're interested in participating in CanScan. And if they are, they'll be asked to help review our results and establish CanScan's priorities and action items. I also want to highlight that our study has 2 person with lived experience co-investigators that are involved in every step. Next slide. So we expect to see some results including barriers being geographic disparities, limited resources, and a lack of support during the transition to adult care. We also expect to see variability between programs, like their model of care, the resources that they have available to survivors, as well as a variability in their funding. Our study will contribute to the growing landscape of survivorship care research by not only focusing across Canada, where some studies in the past have just focused on specific regions, but as well, it was really important to us to actually engage survivors and caregivers. So we're hoping that we will be able to provide a comprehensive review of survivorship care. So that concludes my presentation. We can move to the last slide. I just wanted to acknowledge my PI as well as our funding. Thank you.
Thank you, Gabriella. The next presentation we have is from Nicola. Next slide, please.
All right. Hi, everyone. My name's Nicola. I'm a student in the Care for Kids lab at the University of Calgary. My project explores pain and resilience in sickle cell disease, which, as many of you probably are aware, is a hematological disorder in which abnormal hemoglobin causes red blood cells to sickle. This results in something we call vaso-occlusive crises, which puts patients into tremendous amounts of pain. In terms of treatment, hydroxyurea is a common drug that patients are put on, and then stem cell transplants are also considered for those with more severe disease outcomes and those who could actually find a donor. Next slide, please. So psychosocial research is especially urgent as more children with sickle cell disease survive into adulthood and face challenges in education, employment, and relationships. Compared to their healthy peers, children report greater psychosocial difficulties like social withdrawal, fewer friendships, depression, anxiety, suicidality. These have a negative impact on disease outcomes. That being said, there is still a lack of funding in the sickle cell disease area that supports psychosocial research. So further solidified evidence supporting these trends is needed. Next slide, please. So I decided to look a bit closer at a few psychosocial variables, particularly the duality of distress-based and resilience-based symptoms. So we have pain catastrophizing, which is rumination, magnification, helplessness associated with expected pain. And we also have pain interference, which is the extent to which pain interferes with your life. And then for resilience-based symptoms, I was looking at benefit finding and post-traumatic growth, which are relatively similar concepts. They're used often interchangeably. However, there are some key differences, but for the purpose of my study, interchangeably used. They represent like positive psychological adaptations after processing trauma. Next slide, please. I looked at 3 groups of participants, one group who had undergone stem cell transplant for treatment of sickle cell disease, another group who had not, and then healthy controls. And we also recruited their caregivers to participate in the study with them. The sickle cell groups were recruited through the Heme Clinic at the Alberta Children's Hospital and then partnering health agencies across Canada. And our control group was identified through the HICCUP program, which is like a healthy control program at the hospital here, and community recruitment. All our participants were 8 to 25 years old. Next slide, please. So my first aim was to look at group differences in reports of resilience-based symptoms and distress-based symptoms. My second aim was to look at the relationships between the two. And I expected to see higher resilience-based symptoms in post-transplant groups and higher distress-based symptoms in the non-transplanted group who were still in ongoing sickle cell disease symptoms. And then I also expected to see less pain catastrophizing and pain interference associated with more post-traumatic growth and vice versa. So here's my, next slide, please. Thank you. Here's my large participant demographic chart. I won't go into too much detail, but you can see in under child ethnicity in both sickle cell disease groups, the majority of the participants were Black, African, Caribbean. And unfortunately, this was not reflected on our control group. So certainly a limitation of this study would be a lack of ethnic diversity across our groups. Otherwise, though, relatively similar. Next slide, please. So for my distress-based symptoms, I ran ANOVAs on child and parent pain catastrophizing. Notably, the youth in the non-transplanted group reported significantly higher helplessness compared to their control group. And then parents of sickle cell disease youth, regardless of transplant, report more catastrophic thinking compared to their controls. And then just in general, parent scores are notably higher than their children. Next slide, please. In terms of resilience-based symptoms, I found that parents of youth with sickle cell disease, regardless of transplant, once again reported greater post-traumatic growth compared to the control group. Interestingly enough, though, there were no significant differences in terms of child-reported benefit or burden of illness. Next slide. For my second aim, in the first linear regression model I ran for child pain catastrophizing, I found several predictors suggesting that higher levels of pain interference, presence of chronic pain, and greater perceptions of both benefit and burden of illness were associated with increased pain catastrophizing. And then my second linear regression model, I found that it suggests that parents of children with chronic pain, those exhibiting higher levels of the first two subscales of catastrophizing, which are rumination and magnification, tended to report greater post-traumatic growth. However, interestingly enough, parental helplessness, which is the third subscale of catastrophizing, was associated with lower post-traumatic growth. Next slide, please. So just in summary, adolescents and young adults with sickle cell disease, especially those who haven't undergone a transplant, reported greater pain interference and pain catastrophizing than healthy controls. At the same time, both sickle cell disease groups showed higher post-traumatic growth, suggesting that resilience and positive psychological growth can develop even when their symptoms persist. Caregivers' growth was linked to their child's chronic pain and their own pain-related thoughts, underscoring the importance of family-centered psychosocial care for this group. However, this study was cross-sectional and limited by a small sample size, and like I said, a lack of ethnic diversity. So future longitudinal research is needed to understand how distress and growth evolve over time and hopefully identify opportunities for early intervention. And next slide is my references, but that's all I have. Thank you very much.
Thank you, Nicola. The next speaker is Tamilare, who is going to be talking to us about longitudinal trends in physical activity and smoking among CCS.
Okay, hello everyone. My name is Tamilare, and I'm a third-year health science student doing research in psychosocial oncology at the Care for Kids lab at the University of Calgary. And my research this summer dealt with the lifestyle behaviors of childhood cancer survivors. So childhood cancer survivors comprise a small portion of all cancer survivors, and these are individuals that receive a cancer diagnosis before the age of 15. So research on the lifestyle behaviors of childhood cancer survivors specifically is not very well characterized, and so I set out to gain more insights into this topic this summer. Here in Calgary, childhood cancer survivors receive follow-up care at the long-term survivor clinic at the Alberta Children's Hospital, and that's where the participants for my study were recruited from. So at each clinic visits, patients fill out a questionnaire used by the LTSE staff to assess their health and well-being, and for patients that give written consents, their responses are also used in research. So the aim of my study was to use their responses to determine the prevalence of healthy lifestyle behaviors like sufficient physical activity and abstinence from smoking. And we used the World Health Organization recommendations for physical activity and smoking to guide our analysis. And we ranked participants on a 1-0 scale based off their responses, where 1 is if they meet these recommendations and 0 is if they do not. And I determined the prevalence of participants that meet these recommendations over a time period of 5 years from 2021 to 2025. Next slide, please. So from this analysis, we determined that the prevalence of sufficient physical activity remained quite low over the time period that I studied, at around 50% across all years. To gain further insights, I carried out a binary logistic regression to identify potential predictors, but I didn't find any in my data set. And with smoking, the prevalence of abstinence from smoking in this population is a lot higher, typically around 79.9%. And after carrying out the binary logistic regression, we found that being a male is associated with higher odds of smoking in this data set. And next slide, please. So overall, the majority of participants in this study technically had healthy lifestyle behaviors, with 57% of participants engaging in sufficient physical activity and around 80% of participants abstaining from smoking. However, there's still the 10% of participants that smoke and the 43% that aren't sufficiently physically active. So this shows that there's a lot more work that could be done in educating and encouraging healthy lifestyle behaviors in participants. And future research on this topic could talk about how these healthy lifestyle behaviors actually affect physical health outcomes like cardiovascular health, just to see whether engaging in sufficient physical activity and abstaining from smoking actually offers protective health benefits amidst cancer survivors' heightened risk of health issues from their cancer treatment or the cancer itself. Thank you.
Thank you. The last presentation of this block and of today is Haley.
Hi everyone, my name's Haley. I'm a first-year medical student, I guess second year actually now, at University of Manitoba. I'm doing a BSc Med program, so this is just the first year of my study, so it's not complete, but I'll just talk about where it's at right now. So the title of the study is It's Fertility Discussions Among Adolescents and Young Adults with Cancer Post-Implementation of the Oncofertility Initiative in Manitoba. And my supervisor is Dr. Sapna Oberoi. Next slide, please. Okay, so the first thing that's important within the study is to discuss the population. So specifically, the population is adolescents and young adults diagnosed with cancer. So these are individuals from ages 15 to 39. It's important to recognize that this is a population with unique needs, and infertility is a large side effect of any cancer treatment, whether that be chemotherapy or surgeries, whether that's pelvic, brain, etc. It's important to consider future family planning in all cancer patients, but especially cancer patients within this specific age group. If fertility needs are not addressed, it can lead to significant emotional impact and affect patients' lives forever, ultimately. Fertility discussions are commonly missed or not even discussed at all, so it's important to prioritize timely counseling in order to reduce regret. Next slide, please. All right, so there was a previous chart review done similar to my study with the same supervisor by Collude. So she studied a retrospective review of oncofertility services provided to adolescents and young adults with cancer diagnosed in Manitoba. So she studied 263 patients, 42% of which had fertility discussions documented within their chart. 25% of those were referred to fertility clinics, and 15% underwent fertility preservation. And from her study, she found that oncofertility is a major unmet need within the AYA cancer population, and missed fertility preservation can have lifelong emotional and reproductive consequences. Next slide, please. So after that study, the Oncofertility Initiative was launched by Cancer Care Manitoba. This was started in October 2023. It's designed to improve fertility access, specifically within the AYA population, introducing fertility screening in clinics, clear referral pathways, education for patients and providers, and teamwork with healthcare staff and patient partners. And the goal of this initiative is to make fertility easier and more equal for all AYA cancer patients. Next slide, please. Okay, so the study that I'm doing is similar to the previous chart review. So it's to assess the proportion of AYAs with fertility discussions pre-cancer treatment. It's a retrospective chart review using individuals who are diagnosed a new cancer diagnosis from August 2024 to May 2025. The data is raw data this time around, which is different than the previous study. So 1,600 charts I'm going through and seeing, assessing different variables like their cancer diagnosis, the sex of the patient, the treatment type, the specialty of the sex and sex of consulting physician, what referrals, and if there was gamete preservation. Afterwards, I will then be doing a statistical analysis with the stats team, and it's estimated that there will be around 240 charts. Next slide, please. So the expected results of this study is the hope is that more fertility discussions will be occurring due to the Oncofertility Initiative, and more patients will be getting referred to fertility specialists, and more patients will be going through fertility preservation. The significance of the study is it's important to make oncofertility a normal part of AYA cancer care, and it also can guide Cancer Care Manitoba on future AYA-specific needs. And then next slide, please. And that is all. This is my references. Thank you.
Thank you. So I will echo Stephanie. It was really fascinating to listen to all of you. And even though I was in and out a little bit, I apologize with phone calls. But just fascinating the breadth of topics and studies that you all are doing. And it's really wonderful to hear the work that you're doing. We would love to get your feedback on today. We're looking for ways to improve the whole summer program as well as this particular research day. So please scan the code and give us some feedback. And this is really the end of the summer student program, though I know many of you are still working on your projects as you go forward, which is really going to be wonderful to hear. And I actually wonder, Stephanie, this is just off the top of my head, but whether we could have some kind of brief meeting reunion, in the next couple of years to check in and see how everyone is doing. So please stay tuned for that. We're hoping to be able to continue these type of summer sort of programs. And so we'd love to have you all come back and join us as well. All right, so we'll end there. Thank you again so much. Have a wonderful rest of your summer.
Thank you, everybody.